completed his medical education in England and then made the trek out west to beautiful Palo Alto, where he completed a cardiology fellowship at Stanford University. He's recognized as a leader in the world of heart failure and has numerous publications looking into the outcomes of beta blockers on heart failure. He's currently the director of the heart failure program and the cardiomyopathy center at Stanford University, a position he's held since 2001. So please give a warm welcome to Dr. Fowler.
Thank you very much indeed. I have to switch this on. I can't believe you let me back again, and I can only assume that you're learning to understand some of what I'm saying. Most of my patients tells me it takes about the fourth visit before they have any idea what I'm talking about, which is often very useful, as you'll see as we go through today's presentation, where we're trying to explain to them we're actually going to put an electric motor in their heart. But that's a bit later on, and I'm going to just remind everyone in this room that you've heard a lot about cardiovascular disease, and of course all of you are treating patients with cardiovascular disease, and just remind everybody just how frequent heart failure is. So all our patients, the lifetime actual incidence of developing heart failure, of course the disease of the elderly, is 1 in 5. You can go down these rows here and you can imagine yourselves in a few years' time, and so 1 in 5 of the individuals in this room are going to develop this very common condition of heart failure. Not is it common, but as I hope I will be able to show today, it's unfortunate disease with a very poor prognosis, and it's a disease that tends, despite all our advances in the last 20 years, to be progressive. Now I thought I'd start with the questions, because after lunch we've got to sort of stay awake. So the first question is, what is the mortality for patients refractory? And we'll come back to the bit unfair news at the beginning, but stage D is this stage of heart failure where you're no longer responding to the therapies that we have had as an effective therapy, maybe as the earlier phase of the disease. So I think you press a button.
Yes, they have an audience response.
And I will see what you all think, and then we're going to test you at the end. Bit like a debate. We'll ask the question again and see if we change. The second question, I think, the first question, what is the annual mortality of patients with refractory stage D heart failure? Oh, we are going to get the answers now. Okay, I hope we get in the end. Well, that's at the beginning. We've got that right, but I think we might go back through these questions again at the end. That was my understanding. What is the annual mortality in patients who are stable with class 3 heart failure or maximal medical therapy? You got 17 out of 44 out of 225 seconds, I assume. That's for the ones who read slowly. At least we get some good music. I was rather enjoying the Frank Sinatra, but... Okay, interesting. Interesting. Stable. Number 3, what is the expected 10-year survival for patients following cardiac transplantation? So the median survival. We could probably shorten the time, I think, although with Jaws coming along, maybe you want to get this one a bit quicker. I won't let my children watch Jaws. They wouldn't get in the water for about 10 years afterwards, so I think it should be banned for anyone who wants to do any water sports with their family. You can see why. Probably the music rather than the plastic shark. Okay, well that's interesting. We'll come back to all of these later on. And what is a survival patient implanted with a durable, meaning long-term, not temporary, the Dick Cheney device, if you like, you'll hear about that in a moment, the durable left ventricular assist device, the electric pump that I mentioned at the very beginning. What is the survival at 1 year for these patients? Sorry, I think I put for 2 years for patients implanted with these devices, which of course are available, more and more of them are available on a shelf, unlike heart transplantation. I'm pleased finally we got some English music with Bond, James Bond. Well, yes, I have to. Every program starts like this these days. Good choice of music, Mo. Okay, with that, I think we'll come back to at the end. And as I mentioned, just this annual actuarial lifetime instance, 1 in 5 women, 1 in 5 men. And you can see the prevalence there, 5 million. Annual incidence, 550,000. Mortality, you've got one clue over here, 10% per year mortality amongst this unselected heart failure patient population. 50% of the patients dead within 5 years. And over a million now hospital discharged in the United States, and I think everyone in this room is probably aware of this huge effort from CMS to try and reduce the readmission rate and the hospitalization rate in this patient population. Of that 39 billion with a B, and it's almost impossible to believe that this much is spent in heart failure, but half of that money is spent in hospitalizations for patients with heart failure. Now, when I've been here before, Mo's allowed me to talk about the earlier, easier phases in some stages of heart failure. Sorry, I'm just going to move that maybe. The earlier, easier phases of heart failure, the so-called patients who are at risk of heart failure. I mustn't touch this, obviously. It jumps 10 slides at once. I'm not sure why entirely. I'll go flat out backwards, I hope. What is happening here, do you think? Okay, well, we got back to the slide I wanted to show, and I won't touch the pointer again. I could try pointing at one of the stages, but I noticed earlier on, if somebody pointed at this one, then I felt so sorry for the people over here. So we'll just have to... I'm not going to touch it, I'm not going to risk it again in case it jumps for 10 slides. So you can see that the early phases, I think, are many of you and many of the talks you've had today. The management of hypertension to prevent cardiovascular disease, prevent heart failure. The management of the patient post-MI who's got myocardial dysfunction, but no heart failure yet, the stage B patient. And of course, most of us spend a lot of our day, and every patient I meet, I'm meeting and saying, I hope we're going to keep you alive and well with the strategies that have proven to be so effective over the last 20 years. And I'm going to mention those briefly, but unfortunately an awful lot of patients do progress to this so-called stage D heart failure, where they're no longer responsive to the therapies that have been effective maybe for the previous 5, 10 years. And these patients now develop end-stage heart failure, or so-called stage D heart failure. The goals, of course, are the same right across the continuum of heart failure. You're trying to improve the symptoms. It's a disease that has severe symptoms, a quality of life score that is often rivals that in terms of severity of many of the malignancies. The idea is to keep these patients out of hospital, certainly not a high point for anyone with heart failure to be in hospital, to improve survival, and of course to have a favorable impact, if possible, on this natural history, this disease progression of heart failure. I'm not going to talk much today about the prevention of sudden death. Unfortunately, we still have no drugs that have been shown to prevent sudden death or improve survival. Prevention of sudden death largely involves taking a selected patient population with left ventricular systolic dysfunction, EFs under 30%, and implant these patients with an automatic implantable defibrillator. I think much of the success of this patient population is achieved through a disease management team where you can provide education to these patients about the dietary changes, more and more emphasis, particularly in Europe, and now finally CMS are agreeing to pay for the cardiac rehab and the exercise programs that patients who with heart failure should be in and been shown to benefit from, both in terms of quality of life and survival. Diet, I think, personally, is a crucial part of the regime of these patients, the low-sodium diet and a lot of surveillance. If you just tell a patient what to do once and they disappear, they're not going to do well. We have to see these patients, up-titrate their medications, adjust their medications, provide surveillance, look at their potassium, try and get them on aldosterone antagonists and recognize we've got new drugs now that perhaps allow us to keep patients on aldosterone antagonists with Patrimo and keep these patients on their useful evidence-based medicine. Device therapy, and of course, I'm not going to spend too much time on it, but a huge part of this is the treatment of comorbidities. So I'm so old now, in fact, I'm going to miss, I think, next year's talk, unless I don't know if I'll ever get invited again, but if I come, I expect to have a special celebration because you're going to do it next year, I notice, on my birthday, May 6th. But I also will tell you that when I came to Stanford in 1982, we had 2 drugs for the treatment of heart failure, digoxin and diuretics. That's all we had. In fact, part of the reason I came to Stanford is because survival had been changed, or at least very much get the impression it was changed, of course there was no randomized trials, through cardiac transplantation, which uniquely at that time was being led by Shumway and Ed Stinson with an NIH grant, and they were the people who already put cardiac transplantation on the map when we only had digoxin and diuretics. We had plenty of drugs around that killed patients. I think I was sponsored by a few of them. Amrodone, Milrinone, Vasnarenone, and Oxymone, all the drugs that said get a big stick out, beat harder, beat stronger, and you're going to feel far better. Of course, these drugs, as I say, didn't turn out so well. It's ironic, of course, now that we do give our patients waiting for heart transplant oral intravenous milrinone, I personally, when I get end-stage heart failure, I'm going to pour the milrinone, which is perfectly well absorbed orally, has a long half-life. I'm going to put it into my little martini glass and probably add a little martini to the top of it and save myself the horror of the intravenous line. But we do that to patients on a regular basis. And as soon as you light that fire or give inotropic therapy, I think one has to be aware that you are starting a therapy which, when given orally, was associated with a 53% increase in mortality in class 4 heart failure patients when you take your milrinone by mouth. So this is what we do have to change outcomes in this modern era. And I think it's all self-evident to most of you in the room. We still use digoxin in some patients, somewhat selectively. I'm going to come back to that. I think part of the skill of managing these patients is to choose the right dose of diuretics. I'm still staggered how I meet a patient or two every year who's described to me 6 to 9 months of PND every night, and then on 20 or 40 of furosemide a day. Other patients, one man was actually called. I don't think he's going to hear about this, and of course you won't believe it's true anyway, but it is. I feel like Trump now. He was called Saltenberger. So Mr. Saltenberger came for a heart transplant, and he was obviously well named somewhere in his background, when maybe he was mining in the gold rush. He said, my God, this guy's bizarre. He just eats Saltenberger. We'll call him Saltenberger. So he was wonderful. He was class 4 heart failure, PND every night, and he stopped with little persuasion eating salt and burgers, and he became a class 2 stable patient who's still alive to this day. So I think he and the appropriate balance of diuretics does require, in my mind, the appropriate sodium intake, which is much better managed with lower dose diuretics and low sodium intake than just saying take extra diuretics when you have your high sodium Saltenberger meals. The other drugs I think have all been shown to improve survival. Hydrazine nitrates in the VHS study, ACE inhibitors, that first consensus study, 40% survival benefit at 6 months in refractory patients. It surprises me how often we still aren't using these in these ill patients discharged from hospitals. ARBs, perhaps where you get a dry cough with a ACE inhibitor. Not much role in my mind for the combination therapy. Beta blockers we tend to give homeopathic lip service to. Oh, he's on carvedilol, he's on 3.125 twice a day. I don't think you can see the curve separate in the original trials until you got at least to 6.25. There was a dose response curve to getting to 25 twice a day. Aldosterone antagonists. As I say, no excuse now. We've got to monitor potassium. We've got to make sure these patients are on their aldosterone antagonists. But you get the same reduction in arrhythmic sudden death post-MI, 30% relative risk reduction, by prescribing eplerenone or spirolactone, as you do with an ICD implant. And yet we don't tend to use them. And then ACE plus ARBs, I say, not a huge role. Surprising number of patients come to me with stage D, end-stage heart failure, who have a wide left bundle branch block. Incredibly satisfying patient population to deal with, because a third of those patients will have a dramatic response to their cardiac resynchronization therapy. And we have got a couple of new drugs. Last year, the Entresto, sacubitril, valsartan combination, separate talk, and I don't think I've got a huge amount of time to go into the details and some of the controversy of a trial that was a single trial with a run-in period in relatively hypertensive patients on enalapril, but nevertheless, an apparent benefit, which we all see in the advertisements now, stopped by the FDA, where a comfortable man with heart failure sitting on his chair as the room fills with water and the dog drowns. The FDA, I think, made them remove the advert. It was too frightening. The idea was that to demonstrate that heart failure was a progressive illness, and perhaps we ought to use this more expensive patented drug. Ivabradine, got to be careful not to rob Peter to pay Paul. Corlanda or ivabradine, the drug that lowers heart rate for an effect on the funny channel. Doesn't affect AV node conduction, just slows heart rate. So if you titrate the carvedilol and you truly up-titrate, or metoprolol, the maximum tolerated dose, and that patient has persistent tachycardia, no survival benefit, but a decreased hospitalization instance when we do use this drug that has an effect on sinus slowing. Not used in shock, and I met some the other day who was taking this nice new drug with their atrial fibrillation, where of course it has no impact whatsoever on the conduction through the AV node. So new drugs, we've got to learn how to use them. And of course, I'm not going to go through in detail all the things that you see listed on the right-hand side of the slide, but these patients do have peripheral vascular disease. These patients do have valvular disease. These patients do need special management attention, the agents used to control their type 2 diabetes, their dyslipidemia, their recent stent. And so there's a huge amount of comorbidity in this patient population that has to be managed, and I've just put some of it down on this slide. I wanted to come back a little bit more to this mortality, I mentioned earlier about the absence of a survival benefit in antiarrhythmic therapy, and you say amiodarone there, the same as placebo. Now, amiodarone is our best drug to stop patients firing the defibrillators. Men put up with it very poorly. They seem to end up with post-traumatic stress disorder after the second firing and won't move. Women, of course, are much tougher species, used to having children. They put up with their defibrillator firings quite well, but neither group, men or women, seem to particularly like ICD firings. So nowadays we've been trained appropriately to program our devices to only treat lethal arrhythmias at high heart rates. If we leave these patients get a shot for every slow heart rate, we have zero impact on survival. It seems to be worse. And that applies also for getting people ATP. So program these devices not to shock patients. But of course, once you do start having ICD firings, your prognosis is far worse. It's far worse, perhaps in part because we're forced to use drugs like amiodarone to stop the ICD firing, but the patients entered a new phase of their illness. So I meet patients, probably half the patients I saw on Wednesday had an EFs less than 20%, 17s, 20s, and you're just waiting for the other shoe to drop. And the letter back would almost universally say, well, I don't think he's quite ready for heart transplant yet. He's still out, he's still doing stuff. But when he starts firing his defibrillator, when he starts going back in and out of hospital, when you start peeling back the ACE inhibitor because of renal dysfunction, the carvedilol because of a low output state and fatigue, that's when this patient's in trouble. We do like to make sure all these patients I mentioned earlier have got their CRT device. The original trials were all in late end-stage refractory class 4 heart failure. And in the three curves there, you can see optimal medical management. I wanted again to come back without disturbing this too much, but I want to start trying to point out some of the mortality data. And so if we go there to 630 days, 2 years, we can see that 25% of the patients have died. The survival there is about 65% in the optimal medical therapy. And with the CRT device, it rises significantly at 2 years, as you can see, to about maybe 25% mortality. But you still in this patient population, at a 2-year survival, you've lost at least 10% of your patients, probably more, even with an effective CRT device. So this gives us some of the flavor of when we think we've got a patient and they're stable and they're doing well. That applies at perhaps at the best 80% of them, and 20% of them are going to die, at least within that 2-year period. And you can see the same sort of data here. I think this is very useful data because this represents the sickest group of patients ever put on a beta-blocking drug. Still going backwards. Ever put on a beta-blocking drug. And you can see at the bottom line, the yellow line is the placebo line, meaning maximal medical therapy. These patients were on ARBs, they were on diuretics appropriately, they were taking ACE inhibitors or ARBs, they were on allosteric antagonists. But you can still see that at 1 year, without carvedilol, 20% of those patients had died. And at 2 years, as you can see, about 60%, 40% of the patients had died, the survival was 60%. And so this is about what you will get in a patient population with advanced class 3 heart failure who tolerates carvedilol. You're still going to see a roughly 15% mortality, with 30% of the patients dead at 2 years. And that's really the stable patients. And so what we tend to see is that as these patients progress, we end up making adjustments in their therapy. So this is probably one of the more important slides, because I think it's what we end up doing. We see the changes in therapy as these patients progress. I think we find the refractory very often with their diuretics. Many of us use metolazone, or many people use metolazone. I personally reserve metolazone for the patients I just cannot stand, and you don't know what you're going to do with them, so you give them metolazone, and usually they don't come back. It causes hypokalemia, real dysfunction. So loop diuretic plus metolazone is an extremely dangerous combination, and probably where heart over diuretics really got their bad reputation. I personally think metolazone kills more patients than any other drug we, well-intentioned, give with for heart failure. It's too effective. Potassium's 4, they develop pre-release azotemia. The drug continues to work as GFR drops, and so I would actually often use a loop diuretic plus hydrochlorothiazide. My end-stage patient almost routinely, if he's not meticulous with his low sodium diet, is on furosemide, that's 80 milligrams twice a day, hydrochlorothiazide 25 milligrams twice a day. We call it the supercharger. We'll take it away, we'll give it back, look at their renal function, look at their blood pressure. But metolazone basically is too powerful, too potent, and seems to be associated with a huge amount of arrhythmic sudden death, electrolyte and renal disturbances, particularly hypokalemia. Often you find these patients, the creatinine is 1.8, 2.2. They're not diuresing properly anymore. Systolic blood pressure is 90. Do you leave them on the same dose of ACE and ARB that they were previously well on as their disease progresses? I think you probably don't. We switch many of those patients to a minimal dose of losartan or maybe lisinopril 2.5 milligrams or losartan perhaps 25 at night, a minimal dose. And we often find that we're using hydrazine nitrates, irrespective of blood pressure. I try to persuade my patients not to measure their blood pressure. Every time a nurse comes in to check the wound on their ankle, they said you shouldn't be taking those pills, your blood pressure is low. So we're at odds, perhaps with peripheral perfusion, concern over blood pressure, but in order to get flow out of these patients, in order to minimize their mitral regurgitation, keep their PND down, we'll often switch to hydrazine nitrates, which has no adverse effect on afferent glomerular arterial tone, and will therefore not worsen pre-azotemia. All of us see patients who are well for years on carvedilol 12 and 25 twice a day. Something happens. Maybe they develop AFib. Maybe something else happens we can't really measure or understand. They get into hospital, they come out again. They never get back to tolerating that same dose of carvedilol. Sometimes you meet a man clearly in an upward state, profound symptoms of fatigue, hypotension, worsening renal function, and you simply reduce the carvedilol from 25 twice a day to 12.5 twice a day. He immediately feels better for a few weeks or months. He comes back and you do it again, 6.25. You're shifting down these same gears that he originally benefited from as his disease progressed. And of course, there does seem to be a role, even if we never found it in a trial, there does seem to be a role for meeting patients desperately in a hospital and being forced to start continuous dobutamine, or being forced to start milrinone intravenously. And you wean it off and they immediately deteriorate, renal function goes off. We do it sometimes secretly. We sort of quietly turn off the milrinone, and the next day the patient says, "What have you done? I feel terrible again." So there definitely are patients who tolerate and benefit carvedilol here, have a honeymoon, a sort of honeymoon off carvedilol, off metoprolol here, and you're forced into that patient population. But every time you give that drug as an inpatient, you are lighting a fire that's sometimes quite difficult to put out, to go from the beta agonist or the phosphodiesterase inhibitor through nothing to the carvedilol. And you saw that slide. If these patients get a nice score from Seattle, who's going to survive? Who's going to die? Who's going to need a heart transplant? Who's going to need a VAD? Not being able to tolerate carvedilol is a huge point in terms of poor prognosis. You can't tolerate anymore any androgenetic therapy. The trouble is it needs judgment. And it's quite difficult to know which patient can you keep on, which can't you keep on. Maybe you're trying to control heart rate with atrial fibrillation. Maybe the patient's also got renal failure and they can't tolerate digoxin, but the heart rate's too quick. Do you give amiodarone? Do you add another toxic drug to the mix? These are the patients we're talking about in stage D heart failure, where you see them, you try stuff, but everything you try has got as much downside as upside, or the upside tends to be temporary. The patient comes in, he's firing his defibrillator. You add amiodarone. Well, why does amiodarone have a 27% reduction in meta-analysis of arrhythmic sudden death, but neutral effect on survival? Somewhere we're killing 27% of patients by giving amiodarone. And it's not all through thyrotoxicosis. It's not all through hypothyroidism, lung toxicity, liver damage. There's something clearly about using amiodarone that in terms of the progression of the disease is not beneficial. And yet we're forced into it. Digoxin. Can you give digoxin to this stage C patient? Is it going to be pro-arrhythmic? Have they got too much renal dysfunction? They're going to come back and say, "I don't understand what's wrong with me. I have no appetite. I've lost 30 pounds since I last saw you," and this man comes in with severe cardiac cachexia, not eating at all, and unfortunately digoxin is still 0.125, the amiodarone is 200 twice a day, the creatinine's 2, and he's dystoxic. Don't bother to do a level. That anorexia, nausea, vomiting, fatigue are manifestations of dystoxic. Take it away, he might have a slightly better appetite, but you've lost useful drug. Can you go to 0.0625? Very important to speak clearly there, because in the house staff I had 2 patients sent home the other day taking 0.625. I had other patients, the 0 was important, who were take 0.125, take 0.5 daily, and they were engineers from the Bay Area, so they took about 5 of them to get to 0.25, but they were trying. So things that you have to look out for, details you have to watch out for, and huge potential for things to go wrong in this juggling match of this essentially pre-dying patient. So what do we have? And this is what I have to spend my day with. These patients are all sent to me, and they recognize, or perhaps their referring physicians recognize, they've now got a disease that has a prognosis worse than many of the malignancies that our patients are so horrified by. Our patients are rightly horrified to hear they have pancreatic cancer, rightly horrified to hear they have lung cancer. I remember a patient, I think it wasn't Saltenberger, it must have been his brother, but I had a patient that I looked after about 15, 20 years, sent for heart transplantation, and he came to me, I got terrible news. I developed prostate cancer. I said, my God, that's good news. You had the lethal disease the last 50, and you've lived long enough to get that badge of old age, prostate cancer, that's not going to kill you. That is such a triumph of heart failure medicine. He never quite understood what I was saying. He never kept any more appointments with me. He found that celebrating his prostate cancer was not quite appropriate, but if I'd shown him this slide, I think he would have known what I'd meant. And so, best case scenario for recurrent readmissions, maybe 50% 1-year survival, and recurrent readmissions requiring inotropic therapy, low output state, and you can see that mortality is actually in some studies above 80%. So incredibly lethal disease once you get to this sort of stage D heart failure state. Fortunately, we can spend most of our time doing whatever we can to push that date back, but the majority of patients who get heart failure, you can see that from the long-term beta blocker trials, carvedilol versus metoprolol comparisons, the majority of patients who get heart failure, unfortunately, are going to die from their heart failure. So, am I going the right way? Not sure when it's turned up again. So, that's so we could put to say that these therapies are not effective. And then nowadays we've got this terrible dilemma with each patient. Do we and should we be routinely providing mechanical support for the last few years of these patients' life? And if you're put up for heart transplant, how do you actually get to a heart transplant, this ration resource, and not, if you like, require a left ventricular assist device, and our current prioritization seem to get there. It's not well understood by patients very often. They say, well, I might not want to transplant now, and I'm feeling not quite well, but I've looked on the web, and I know I've got a progressive illness, so my AF is 20%, so I want to be put on the waiting list now for a heart transplant. And I think many programs did that. And they found they had 200 people on the waiting list, and the person who was put on last would invariably die, and the only ones who could survive that 2, 3, 4 year waiting period to get their transplants were the ones who invariably didn't need it. So the response, and partly the response, I think, between the competition between program, where there's the socialist in me, no certificate of need, the response is to make sure that the transplants go to the very sickest patients. And rightly or wrongly, amongst those group of very sickest patients are the people who agreed to fly with the Wright brothers. The early adopters are the patients prepared to put in pulsatile, left ventricular assist devices, sometimes air-driven, mechanical issues with many of them. And so if you got an LVAD in because you couldn't survive the transplant, you were given a month as a 1A, the stop you had 2 years life expectancy, you were just given that as a sort of gift from a committee, could only decide that. The rest of the time you were 1B. But of course you were ahead of every single patient who hadn't yet got their LVAD. So we agonized tremendously about who should get a heart transplant, who should win the lottery to have that 50%, 10-year survival, 50% plus if you're younger. Who should get that? And unfortunately at the moment, most of the patients who do get transplant do it with the Dick Cheney technique, where they get a left ventricular assist device as a bridge to heart transplantation. And these are the sort of categories that I'm talking about. Long-term mechanical support could be bridge to recovery. We have had a few patients, younger patients particularly. Maybe they have acute viral myocarditis, maybe they have a short history, maybe they have dilated cardiomyopathy, but not a long history. You can unload that heart, put an LVAD in, and you can surprise yourself by finding some of those patients will recover and the LVAD will come out. Unfortunately, in the United States, the number of patients who have that extraordinary, incredibly useful role for the VADs is quite slight, but people are trying to enhance that at the moment. Protocols taking place, including Stanford, where you get some stem cells at the time of your LVAD to try and improve the probability that you could be weaned from the LVAD and recover and go back to where you were, recovered to some extent. Bridge to transplant, I've mentioned. You can see why it's done. You can't wait for a heart transplant. You're ill, and you're not going to survive to get your heart transplant. And frankly, I don't think any program that I can think of has done a large blood type O non-prioritized, waiting as a so-called stable outpatient for the last year or two. Stanford was about the last program to fall. We used to think we had a just-in-time inventory. We wouldn't list more than about 50, 60 people a year, and that's the number of transplants we could do. And we could transplant patients from non-prioritized status. Almost impossible now. And in reality, although many patients are getting their LVADs as bridge to transplant, they are de facto turning into destination therapy. And if they're thought to be too old for heart transplant, have comorbidities up front, this patient in the pink box are told they're getting their left ventricular assist device as a long-term final treatment that they're going to get without much hope of weaning and with almost no hope of cardiac transplantation. Now, I put the green box there, the pulse style flow, because it's how I can link together the old trials, but nobody is implanting devices with pulse style flow. I think my patient at Stanford in 1985, I think I whipped downstairs, looked at the sheep, before I went back to the patient and said, oh, we got this thing downstairs that you're going to be the first patient in the United States that gets a pulsatile left ventricular assist device with 2 valves in it, and mimicking exactly basically the normal pulsatile flow that we might have in a normal heart with an inlet and outlet valve. This patient actually survived, bridged to transplant, lived about 20 years post-transplant. I think that was 85. Anyway, that's a pulsatile device. That was one we developed at Stanford called the Novacor device. That company's gone bankrupt. Nobody is using pulsatile flow. But you'll see it was the pulsatile flow that was looked at in the first trials that seemed to show benefit of these devices, considerable benefit compared to optimal medical therapy, but really also illustrated the huge number of morbidity associated with these devices. So before anyone puts up for transplant or puts up for LVAD, I think we've heard a bit of this before. Are there any contraindications to VAD support? And obviously end-stage liver, lung, or renal disease is something we debate about. I think for destination therapy, you don't really want somebody on dialysis. I can't say we've never done it. We have one patient where he got it wrong, and we thought their kidneys would recover, and they didn't recover from his LVAD operation. He's on LVAD plus long-term transplant. He's doing well, but the logistics reporting, none of the dialysis programs want to take him. Has he got metastatic malignant disease? Has he got an active infectious process taking place? Can he take systemic anticoagulation? There's a huge risk of thrombus formation with these left ventricular assist devices with mechanical parts in them. They've got to have chronic oral anticoagulation. The standard therapy is aspirin and warfarin. Have they had a history of GI bleeding? Have they got some other reason where they're going to be able to not tolerate this therapy? And moderate to severe RV dysfunction. If you just put an LVAD in, you're as good as a weak chamber. The right ventricle might well enjoy the unloading of the left ventricle, but it's still got to cope to some extent. If you leave these patients too long, you're going to have right heart failure post-operatively, maybe temporary support, maybe long-term BiVAD support until you get them to transplant. You've basically chosen that patient poorly. What are the other issues? The support, have they got someone to help look after them? Suppose they have an early CVA. Suppose they get recurrent line infections. What are their wishes? All our patients are seen by the palliative care group, so we actually got some sense, and they've written down for us what they would want done under certain circumstances, where their whirling Derbyshire is keeping them going, but they have profound brain injury. What would they want? They're completely alive. Do we turn it off, or do we leave it on? And we have to have that sort of sorted out beforehand. And can they cope? Can they cope even with change their batteries reliably? Can they look after their wound? And what are the patient's goals? Many heart failure trials have shown that a patient would sacrifice a few years of life for a good quality of life. Most of these patients are going into this because I consider them to be walking wounded. They will come to clinic and they say, I don't want to live like this. It's not a great response to say, don't worry, you won't very long, although that's often the truth. If they're stuck in this sort of limbo world and you haven't got too sick and they can still do it, this is the patient population that if they can improve their quality of life, if they can get back to being with their family, and they cope surprisingly well with a therapy that seems very Dracula-like when they first hear about it. They find the whole thing terrifying, but actually it's surprising how well they'll do. This is another crucial slide. If we wait till these patients, if you like, are Intermax score 1, which I'd rather give this rather awful title, Crash and Burn, but I think we all know who that is. It's a Friday night call from Mo, who said he's got a really nice guy, and she just had a baby. She's actually a woman, this particular guy. And she's just had a baby, and she's got a wonderful family, and she's now in profound multi-organ failure with cardiogenic shock from acute pericardial cardiomyopathy. And of course, in that woman and that person, you're going to do everything you can, but they might be Intermax 1, maybe they haven't quite got multi-organ failure yet, in which case they're probably not to survive. Can we tie them over with ECMO? Can we give them temporary support? And so the Intermax 1's group is a sort of Friday night special patient you don't know, you haven't planned anything for, and yet they're ill, and this is a way potentially to save their life. Those patients do not do well, as you'll see in a moment. The other groups, frankly, all cope. And you can see they put a mortality there, which isn't quite right on this slide. It's not my slide. You've got 100% survival when you're class 3, which of course is not right. Maybe they mean 100% 2-week survival. But you can see there that as these stages, Intermax stages, go from 1 to 7, you end up with a more and more stable patient. And the great art at the moment is to find the sweet spot as the results of LVADs improve. And you don't want to wait to the very last minute where, however good your technology is, your patient's too sick at the time of implantation to benefit. So these are the criteria of the 2 patient populations. It's, I think, pretty self-evident from what I've said so far. Who needs a heart transplant? Who should get a destination VAD? And these are the available devices that were largely used. These are the approved devices, approved by most insurance companies, approved by CMS. As you can see, the HeartWare trial as destination therapy, I'm going to show the data for. Presented exactly a year ago, shows equivalency to the HeartMate 2 device, and I'll show you some of the differences. But I think there'll be 2 devices very soon that are approved as both a bridge to heart transplant as destination therapy. Now, I always tell my patients that I assume that Dick Cheney's doctors were Republicans. I just assume that. Because I said if Dick Cheney's doctors were Democrats, of course, none of what I'm going to tell you really applies. Because we were just trying to get our own back with some cruel and unusual punishment. And don't forget, I come from the Bay Area, and I know I'm in Reading. But anyway, and just go a bit further, we probably find Dick Cheney sitting very happy and very well with his 1 year of book tour with his bridging left ventricular assist device put in him. I think that's a picture of him demonstrating his device to the media. He would freak them out. Every time he was doing his book tour, he'd start unbuttoning himself and say, I got this and I got that. And people in the room would be terrified when he started disconnecting his batteries and the alarms would go off. But he was quite sensible because he had 2 previous bypass operations. He wasn't that young anymore. And he was wise enough not to announce that his LVAD was, he wasn't sure yet whether he'd have a heart transplant, as opposed to having it as destination therapy. Well, in reality, nowadays, a man in that age who's doing well with his VAD probably wouldn't or shouldn't be put on the heart transplant waiting list at the expense of Mo's 27-year-old dying woman who's going to compete with him directly for this limited resource of a heart transplant with the 10-year 50% plus survival. So it's a difficult equation, difficult now to do it, but this is very widely accepted now. Unfortunately, as you'll see, as the years go by and we're putting more and more patients implanted with VADs to get to transplant, like any good Ponzi scheme, when you're trying to get something else of lesser value, but you're having something lower value to get something higher value, one of the definitions of a Ponzi scheme, after a while, it doesn't get you anywhere. You've still got hundreds of patients with their VADs waiting, and they're now waiting, most of the patients, blood type O with a VAD, are waiting over a year. So you're getting back to almost where you were without the VAD. So on the other hand, it could be argued, depending how ill Dick Cheney was, that without the VAD, he wouldn't have survived. Wouldn't have survived to have this conversation, VAD or transplant. So it's part of the dilemma that linked together the 2 issues. Here's the Thorotec device that Dick Cheney had. It's an axial flow device, draws blood from the apex of the left ventricle, has a little pocket in for the device, with a risk of a pocket infection, blood put down around the side of the heart and returned to the aorta. You've got to have an incompetent aortic valve, you can't have a mechanical valve. You have to oversew that to stop thrombus formation. The valve might not close. It seems very draconian. It seems very strange to patients. They're going to put this inside themselves, but it goes remarkably well for the majority of patients, at least initially. And that's the sort of setup. He wears his batteries. He comes to the clinic, and theoretically, he needs 2 medicines. Theoretically, warfarin and aspirin, because it never quite works out like that by the time you're dealing with the other issues these patients, of course, have. This was the device, though, the original HeartMate device, the HeartMate 1 device, and it's not well shown there, but it has a pusher plate, it's a pulsatile device, and it was this 10-year-old study now from 2001, the REMATCH study, which really reminded us just how sick patients were with refractory stage D heart failure. One group was randomized optimal medical therapy, and the other group was going to give a long-term device, the pulsatile version of this left ventricular assist device. This gives you some idea who the patients were. EF 17%, creatinine's 1.8, high wedge pressures, and this is the data. Now, at 1 year, the device looks very dramatic. You can see on the top, the patients on the device had a 50% survival at 1 year, whereas almost 80% plus of the patients on optimal medical therapy died. The trouble is, as you can see, by the end of the slide, there are no survivors at 2 years to speak of in either group. But in terms of proof of concept, it showed that it's a somewhat flawed device with a lot of mechanical issues. A lot of the death was when the patients turned down their pump replacements because the pumps were failing in this original air-driven pulsatile flow. I was going to skip that one. It just shows in its early days the patients who got the survival benefit were largely the patients who were also receiving intravenous inotropics. So this is what you're comparing when you see the patient. This is the 10-year survival that I mentioned to you in the modern era. Of course, the purple line doesn't quite get to the modern era, but the 10-year survival in different eras of heart transplantation. So instead of 50% 1-year survival, you've now got, back to the questions, 50% 10-year survival. So a very different outcome, and this is some of the reasons that the patients with heart transplants don't live forever. And non-specific graft failure, by 20 years, 12% of them develop non-specific graft failure, rejection. You can see some of the other reasons, chronic infection, why patients don't live forever post-transplant, but it's certainly incredibly effective therapy. They can swim, they take the immunosuppression, they have an effective drug, and they're completely rehabilitated. But this is the problem slide. The green is the number of transplants done in the United States. The yellow, I think, is Europe, and red is other. So we're down to 2,500 patients. We showed you the incidence of over 500,000 patients. We showed you the mortality in this patient population of anything from 50 to 80% per year, and we can only do 2,000 operations. We have no good mechanism to work out how she would ration and redistribute those hearts. In fact, it's illegal to say, well, we're going to put them in the young patient. That would be illegal in the United States. It's also, for what it's worth, illegal to say, I'm not going to give this patient because they got Downs, which comes up on a regular basis, or is mentally impaired from the illness perhaps that's given their cardiomyopathy. So they're very difficult issues to work out how these hearts are distributed. And you can see most centers, I think personally, I think there are 2 million centers, are only doing 10 to 19. Last year at Stanford, we did the second highest number in the country. Cedars did the most, we were the second both, and I think we did about 70. But there's small numbers, really, per program for the number of people involved with it. So this again, this is another way of showing that survival data. The children, of course, too young. I put it up there to show that younger patients can live longer. Median survival over 50%. And if you like, that so-called conditional survival is 13%. That's a survival, median year survival, 13 years survival if you live that first year, which, as you can see, the majority now do. Most programs can have a first-year survival of above 90%. And then after that, you're going to live a median of 13 more years. So these are the 2 treatments. I put up the rematch trial because you have optimal medical therapy in red, a nice green line of an effective therapy, at least at 1 year. But that's what you're comparing it with in these patients, the yellow line. And all the patients have to go through the VAD and survive the VAD to get a transplant. But more and more, that's how it's been done. I think I'm going to take it along this, so I'm going to skip forward a bit. So rematch, you can see 50% survival, LVAD at 1 year, 25% medical therapy. But there were now better devices. And all the devices we use now are continuous flow devices. You saw the axial flow device that Dick Cheney got, the HeartMate 2. There's a second device I'm going to show you called HeartWare in a moment. And so this is a comparison between continuous flow, HeartMate 1 and HeartMate 2. These are the 2 devices just illustrated, one with the pusher plates and the pulsatile flow, and the other device, the continuous flow in the axial flow design with a pocket underneath the heart. And you can see just simplistically that the survival benefit now in this modern era is considerably better with this continuous flow device compared with the pulsatile flow device. And so the slide on the right-hand side, the second panel that came up, shows the optimal medical therapy in gray, the 2 trials that had the pulsatile flow in the middle, where you saw the 50% 1-year survival, and then the continuous flow devices with the considerably better survival. And that's really what we're looking at now, and that's why this is what's taken place. The vast majority of patients now, 40% in this slide, with LVADs, a small number there with ECMO, as you can see in the orange, the RVAD as well, in red as a small line, and the yellow group RVADs plus LVADs, that the 50% of the patients now, and this was 2030, it's even more now, are coming through to cardiac transplantation through a bridging left ventricular assist device. And this is some of the actuarial curves of what actually happens to you. You've got about 79% survival if you have ongoing support, or you've recovered, or you've been transplanted. 56% of the patients by 18 months in this analysis have been transplanted. Ongoing device support was still present in about 20% of the patients. 20% of the patients had died, and 7% and 2.5% had recovered. And that's the sort of natural history you might see in a patient who gets a left ventricular assist device as the bridge to cardiac transplantation, getting worse and worse each year as the patients don't get cardiac transplant, but are left particularly with the type O device. Type O blood type left on the device because of their blood type. Here we see 73% 18 months survival in patients who continue to receive support and don't get transplanted. This again is a rather busy slide, but it tells you somewhat simplistically that the Intermax 1 patients don't do well as the more stable patients. And the group there that did best, the one who'd been stabilized and were coping and stable on intravenous inotropes, who get their LVADs from that status, and their so-called Intermax 3. Now, just to sort of finish up, a few slides just to finish with. How am I doing for time? A little bit late. Just to sort of try and get this up to date, because there's been very little recent publications on this. So this is from University of Minnesota, who actually looked at their data in 3 time periods. So they had 278 patients who all received the HeartMate 2 continuous flow device with a pocket. And you can see they divide them into 3 groups: the first period of time, the second period of time, and the third period of time, group 3. The number who become bridged to transplant actually goes down during this period of time as more destination devices are shown. You can see here the survival from destination therapy versus bridge to transplant, different patient populations, but you're approaching about a 20% mortality now at, it's about almost a 30% mortality at 2 years in the total population. But if you look at the later periods of time, and we do look at survival by era, you can see now that you've got to 75% survival, beginning to look more respectable. 75% of the patients alive at 2 years in this modern era of patients who are being treated with continuous flow devices. Some of the risks are shown in this slide, but I think it's quicker to go forward and show it like this. Freedom from stroke, 5 years out, about 25% of the patients have had strokes. So a huge risk to these patients, and about half these patients are major disabling strokes. GI bleed has become a huge issue. We can talk about that later on if you like, but the circumstances of a continuous flow device and the effect on von Willebrand's factor, the effect of having no pulsatile flow on the gut, is leaving a lot of these patients vulnerable to GI bleeding. And that's a huge issue because, of course, if you take away the anticoagulation, then you meet the Achilles heel on the other foot, and that's, of course, pump thrombosis and raised LDHs. So you can see the GI bleed incidence extremely high. About 25% of the patients will have a GI bleed by 2 years. Freedom from driveline infection is a little bit better, but again, driveline infections usually be treated with a long-term or suppressive or brief course of antibiotics, but nevertheless, a major risk for getting a pump infection needing a pump exchange. And then hemolysis usually means the pump is thrombosing, and there's clot formation, and those patients often also have to go back for a pump exchange. And here you can see some of the pump exchange rates. So a lot of morbidity and mortality. The hope is that this new device on the right, which is the same basic design as the HeartMate 3 device, won't require a separate pocket, is essentially an interpericardial device, and now this is a bit like your clothes dryer, it's a centrifugal pump. And this pump will take the blood through a middle course, spin it round, and it'll come up the side in a mag-legged motor with no bearings, and somehow, I don't know how the fluid mechanics people do it, without hemolysis unless the pump is going wrong. And just very briefly, this is sort of current era data. This is freedom from stroke, disabling stroke, and survival. Comparing the 2 devices, and clearly the 2 devices are actually very comparable. The surgeons prefer the HeartWare device because it's a much simpler operation for them without making a pocket. And this is the new version of the HeartWare device, again, showing good survival, overall survival, compared over 61% versus 67%. So in the 60s in this particular study where they're all destination therapy. So these are some of the things you can do with your VAD. You notice nobody's swimming because they do have a drive line. They do have a controller. And they shower, but they have to carefully cover it up and keep it dry, so there's no swimming. We do have people fishing. We got one man who told me he was deaf. He was the kind of man who paid his bills. With end-stage heart failure, he was out every day in the Pacific, fishing on his own in a boat, and now he still fishes with his vad. He says he's got a special, really good water skin type stuff that keeps the vad dry. And so we say, well, we quite understand you shouldn't be doing this, but you have got to pay the bills. So we got to have a price. This is another man, actually is one of the early pulse to devices, just to show you really can do almost anything that you want to do with these devices. And again, just to summarize, patient selection is still primary. Do the patients really want it? Do they understand who it is? Do we get them to the right point of their disease? There's now about twice as many LVADs being implanted in the United States as there are heart transplants being done. And about a third of those is for destination therapy. So they've become important therapies to bridge patients to cardiac transplantation. The 3 trials I showed you briefly show that they're pretty effective as destination therapy in incredibly carefully selected patients who are prepared to put up with some of the potential comorbidities. And the devices, frankly, and our way of managing the devices and getting the patients through the device implantation, long-term management, with big teams of people specialized in looking after this group of patients, has become very effective in improving quality of life and survival. So I'm sorry I went on a bit too long, especially after lunch, but thank you very much for having me back. Thank you. Thank you.
Thank you, Dr. Fowler.